living thing, isn't it? So what purpose do the bones serve, and what happens when things go wrong?
Yes, so the bones serve quite a number of functions. You would be aware that it's protective. So the bones which make up the thoracic cavity or the chest wall serves to protect soft organs like the lungs and the heart. The skull is a bone, so it protects the brain. So it's very protective, and at the same time offering structure and form to the body. It stores quite a number of minerals, calcium being one of the important ones, and acts as somewhat of a reservoir to ensure that the amount of calcium that we have circulating in the body, for instance, is kept within normal. The bone marrow is very important in producing cells. So red blood cells, white blood cells that help with fighting infection, as well as platelets that assist in blood clotting. So quite a wide array of functions. And when things go wrong and the strength of the bones is significantly reduced, then the risk of fractures is there. And there are a number of things that can contribute to weakening of the bones, which we will get into as well over the course of the next few minutes.
Mm-hmm. Good. So we'd certainly like to hear more about those, because we had some questions about what the connection is with lupus, but on the bones, why is it, bone health such an issue in lupus patients? But first, tell us more about, what happens to the bones over time. Somebody asked a question, if there's a particular age where you develop bone problems. So tell us a little bit about what happens to our bones over time, and what are the things that we can expect even under normal circumstances. And then we can probably address this question about the lupus issues.
Okay, right. So typically we start off in childhood, in our infancy, at around the same, and I mean, men compared to women. So females compared to males, we typically start off at roughly the same. Boys a little bit more. And the strength of our bones and the bone content, the amount of bone in our body, basically what we tend to refer to as the bone mass, increases steadily as we grow. So for the initial decade going into early adulthood, bone mineral content and the bone mass increases quite significantly. We attain a peak bone mass at about 30 years old. So the most bone we'll have in the body is round about when we hit 30. And for every single age, men outdo the women. So the bone mass in men is always higher, in healthy men, always higher when compared to healthy women. When you hit 30, we tend to plateau, so we level off. And then we continue a decline, both in men and women. But at the stage where women become menopausal, where we stop having our regular cycles, we know that our hormonal levels dip significantly at that juncture in our lives. And if you notice on this slide, I'm not sure you're seeing the slide, but there's a significant decline. There's a large drop at around menopause in women. But as you can see, the men continue to decline slightly. They always continue to outpace the women in terms of bone mass. So women are always at higher risk of bone mineral problems. And this is worse after they've gone through menopause.
Okay, wow. Yeah, I love this graphic. And so I'm hearing a lot of things. So we have the bone increasing in mass during our childhood and adolescent years, plateauing, in our third decade, the 20s, and then going down, especially from there on, especially in women. Yes. And in menopause, just dropping very rapidly. So it seems as if there's a window of opportunity there to actually get the best strength out of our bones, to start from a higher place. Yeah. You're thinking about the density. If you're starting from a higher level, then even though it's declining, you still have some reserves, right? So what are the things that contribute to the strength of our bones? You mentioned the hormones, because the men have more. So what are things? Is it our diet? Is it our, what are things that contribute to this peak of the bones?
Right. So there are a number of things that contribute to peak bone. There are different cells that play roles in terms of bone building up and bone breaking down, because there's constant breaking down of bone and building up of bone in a process we call remodeling. And we have to ensure that there's sufficient substrate in the body to ensure that the bone building capacity is improved. So diet serves a significant role. And by diet, we always promote healthy lifestyle, healthy eating. But of significance is calcium intake. Calcium intake, especially in the form of nutritious meals. So not necessarily supplementation per se. The absorption of calcium is always most efficient when we eat foods containing high calcium, or dairy products for those who can tolerate it. If it is that there is an intolerance, then supplements can be utilized. Vitamin D is also a very important mineral that helps with bone building. It is present, or the sun, when we go out in the sun, it facilitates the conversion of vitamin D within the skin to the active form. But we are aware that there are some individuals who are just not able to be exposed to the sun for various reasons. And persons with lupus come to mind, because often they're exposed to sensitivity. And in these circumstances, we would suggest vitamin D supplementation, ensuring the levels within the blood are normal, and then supplementing it to make sure that the levels remain normal. There are other lifestyle changes, increasing physical activity. So specifically weight-bearing exercises, walking, squats, running, if it can be tolerated. There are other lifestyle interventions which I would suggest persons probably try to stay away from, which include reducing alcohol intake. We know that excessive alcohol intake does have a negative impact on bone mineral density and bone strength and content, as well as cigarette smoking. So reducing those lifestyle exercises or things that would promote bone loss, and ensuring the diet and the exercises are as we would recommend in individuals, not just with lupus, in individuals in general, to make sure that we attain the maximum peak, so that even though, as you mentioned, Dr. Solary, there's a fall off, if you're starting from a higher place, then that fall off is going to be less significant in the long term.
Okay, wow. Okay, so I'm seeing a lot of bells are going off, at least for me, because we, as rheumatologists, we see patients throughout the trajectory of their lives,
Right.
They said 20% of our lupus patients actually have onset of lupus in childhood. So you're telling me about this growth period,
Right.
and all the things that must take place. The diet must be good. You must have a certain calcium intake. You must get vitamin D.
Right.
And we're seeing some issues there, as you mentioned, sun exposure can be an issue. Some of us have to take supplements. So this is really a key thing to be aware of. And then you're describing some other interventions. How active you are
Yes.
is a big factor in terms of strengthening the bones and optimizing that peak bone mass. But these sound like interventions you could benefit from at any age, whether it's in your growth phase, the maximum, or even when you're later on and you're trying to really catch up or preserve what you have.
Yeah, certainly at any age, and exercise will go beyond just bone health, general health, cardiovascular health, muscle health, improving muscle strength or reducing falls. So the benefits of routine exercise cannot be overstressed.
Yes, weight-bearing exercise, you said.
Weight-bearing
So
exercise.
bearing that in mind, yes. Walking including.
Yes,
so
walking
included. Yes. So this is a good point to bring up some issues. So as it relates to lupus, and what makes lupus persons so vulnerable to issues with the bone. So we've heard the routine things to do with diet, exercise, whether people smoke and drink and so on.
Right.
And that's for the general population. So we're all just as vulnerable as the rest. But there's some particular issues, aren't there, when it comes to lupus?
There are some particular issues. So these issues might be disease related, and they might be medication related. With regard to disease related issues, we have seen that in patients in whom there are recurrent flares, in whom the disease activity is high over prolonged periods, that this itself, even without any contributory medications, may in fact result in a reduction in your bone content over time, just from that inflammatory process. So the more quiescent or diseases, the lower the risk of this happening. The more active the disease is, the higher the risk of osteoporosis and bone-related issues. There are some other factors which need to be mentioned, including steroid use. It's a double-edged sword to an extent. Glucocorticoids are a very big part of the management of individuals who have lupus, steroids, especially at the times when they have flares, when they might need higher doses than normal. And we do know that the cumulative dose, which is the total dose that you've taken over a lifetime, the higher that cumulative dose, the higher the risk of osteoporosis. But sometimes this is what is required to quiet the disease. So it's kind of a two ways of looking at it. Glucocorticoid or steroid use in itself as well, we know is very strongly associated with the development of weakening of the bones, especially at higher doses. So persons who are on high doses for prolonged periods would be more at risk of having reduction in their bone mineral density or their bone mass over time. So very often, we might find that our rheumatologist specialist might see it necessary to start off at high doses, but over time, as things settle down, there might be alternative agents that can be introduced in place of or to be used in conjunction with the steroids, albeit at lower doses. There are certain other disease-related factors, which include the specific antibodies which you have, which sometimes we have seen a relationship with. The relationship is not as hard and fast. I'm not sure what your take on it is, Dr. Soler-Reed, but certain individuals with specific antibodies may be seen to have a higher risk of osteoporosis, but at the same time, those are probably the individuals we're advising to stay out of the sun. So what is contributing to the bone mass changes is questionable, and I think we have done enough research to tease it out enough. There are some persons as well who, by virtue of having lupus, may have other inflammatory diseases of maybe the intestines. So absorption is not very good. So even though you might be consuming enough calcium and vitamin D in your diet, if you're not really absorbing it well enough, then again, that might contribute to a reduction in your bone mass. So it's multifactorial. And I think this slide picks up a few of the points that I've just mentioned.
Okay, great. Yes, I hope everybody, I heard that some people didn't see the slide with the age. So I'm hoping everybody has seen the slide, this other slide showing the different factors.
Right, so
yes.
I'm not seeing it very clearly, but this is divided into what we call modifiable and non-modifiable factors. So the modifiable ones are the ones you can do something about, but then the non-modifiable ones, age, you can't really do much about that, your family history, your genetics, etc. So we're trying to focus on making changes to the modifiable ones to improve on bone health.
Okay, awesome. Wonderful. So we're not powerless in the situation. So we've heard all the things. But this is really interesting to know that on one hand, having all this uncontrolled inflammation is actually compromises your bone density. So when the lupus is out of control, this also contributes to the reduction in the bone density. And at the same time, what you use to control the lupus matters, because steroids are, we've seen that they have some negative effects on the bone. And osteoporosis is a word that we're hearing a lot, and low bone density. And there are even other bone complications that we come across, especially in lupus patients. That's another term that we may get to if we have time, called osteonecrosis. And that can be a devastating issue. And so we can dive into some more of these questions. So we've heard about the importance of, working with your doctor to introduce other drugs that help to control the lupus. For us, we call them steroid-sparing medicines, okay? Right. Because this sort of symbolizes what our goals are in treatment. The first goal is always to get the lupus under control, because we don't want it to cause damage. But the second goal is to keep it under control without steroids, or with the minimum amount of steroid exposure, because you just explained that it's a matter of that cumulative effect, the dose as well as the duration. So both of those contribute. So that's good for us to be aware of and to work with our physicians on that. So here's a question about osteoporosis, and what are the signs of osteoporosis?
Right.
Do you have symptoms? Do you feel it?
Mm-hmm. So typically patients do not feel, there are no associated symptoms of osteoporosis. You don't have bone pain or any such thing unless there has been a fracture. And often these fractures go unnoticed, really, because they're what we term fragility fractures. The bones are so weak that it doesn't take a lot of trauma to cause a fracture. So you might fall from standing height, for instance. In somebody who has normal bone density, if you fall from standing height, you should not really have a fracture. There are some persons who sneeze and have a fracture, or they step down an extra step without noticing and they have a fracture. So when these fractures occur, they might go unnoticed, they're unexpected, but then the pain that comes along with it might be what alerts you, especially in vertebral fractures. So fractures of the spine, for instance, may cause chronic pain, back pain. And it is really just when these individuals are being investigated with their x-rays or other imaging that the fractures are picked up. There often as well, people would notice that they're getting shorter over the years, or they're hunched forward a little bit. They're losing height. And while this is not diagnostic per se of osteoporosis, is one of the signs that we would typically see in persons who are older. So the signs are not always very evident until things have gone bad. This is actually demonstrating what healthy bone looks like compared to bone that has osteoporosis. And if you notice the network or the inside of the bone is quite nice and dense for the healthy bone, but then it looks very, it's not as dense and looks very unhealthy and in individuals with osteoporosis, and this increases the risk of fractures quite significantly.
I see why they call it osteoporosis. They look very, it looks very porous.
Right. It looks very porous.
It's like some limestone or something, very, very porous. Wow, so this is really graphic illustration. And what you said earlier, that, in terms of the signs, the main thing we worry about with loss of bone health is fractures. Right. But the process that leads you to this stage where your bones are so fragile can be silent. Like you can't wait for pain to know if you're losing bone density, right?
No.
And even when you get the fracture, you may not even feel it, right? Because I've had some patients who have just noticed they've got short.
Yes, absolutely.
They're suddenly short, or their posture is spot. They're hunched over,
Right.
So tell us a little bit of how that happens. How do you get that curved posture, or you suddenly lose height?
Yes. So the bone, if you remember when you were in school, maybe there are a number of small bones in the back that we call the spine. They're called vertebrae. And osteoporosis, it causes these little bones to become very fragile. So over time, sometimes what you have is what we call compression fractures. So they actually just compress on themselves. They get shorter and shorter over time. And this results in the loss of height that you see and the change in posture. Just bones pretty much crumbling
Yeah.
over time.
Yeah, very brittle. So you can actually, and you mentioned fragility fractures. So you can get fractures without much force at all in your limbs. You know, we worry about the hip
Yeah.
and different bones, the forearm and all kinds of bones, your feet. And then now this back one can
Yeah.
just kind of sneak up on you. And some people can get pain with it, but not, yeah.
So it can cause chronic pain, and it's typically when patients complain of this and the investigations are requested, the X-ray, etc., that you'd pick up that there are multiple fractures, which this individual was just not aware of, and probably can't even recall how it happened because they did not take much trauma to result in that fracture.
So here's a question, you know, a couple of questions. What can we do about this kind of situation? You spoke about preventing bone loss. You know, when there's already evidence of bone loss, you know, what can be done, you know, before or after even you have a fracture? Is there anything that can be done to deal with this?
Right. So what you want to do is try to maintain the amount of bone that's left, pretty much. And having identified issues which are modifiable, you're addressing these. But there are certain medications as well that we know work to improve on bone density and as a result, reduce the risk of fractures. These medications they're available in Jamaica. They can be administered either in tablet form or injection form. And with the tablets, we typically prescribe it once a day, once a week. And the injectables can be done once a year, once every 6 months, depending on what's available and what is best for the patient. Not all of these are okay for everyone. Some of these tablets and injectable agents should not be used in persons who have kidney impairment, significant kidney damage, which we know lupus does increase the risk of. So that's something we need to check first. And before treating patients with these, we also need to make sure their calcium and vitamin D levels are okay. So persons need to have these checked. And if they're not optimal, then we need to optimize before treating individuals to make sure the outcomes are best.
Yes, and I've seen where the evidence is that many of these drugs really do significantly reduce your chance of risk of fractures.
Absolutely.
And that's really what you want to avoid. Yes.
Because yes, go ahead. Sorry.
Well, we know time has really flown on us, but this is so you know, important. We know how we fix regular fractures of the bones. You know, we go to the orthopedics and they put a splint or a cast or pin it or something, or replace it in the hip. But what do you do if you already have curvature of the spine? So that's one of our questions.
Yeah.
If you already have curvature of the spine, can this be corrected?
So the indications for surgery, so these are patients who might end up seeing the orthopedic specialist because of the vertebral fractures. And there are certain things that you would need to look for. So are these fractures appearing to be unstable? If that's the case, and we think the spinal cord is at risk, because with compression of spinal cord, you know, that can cause paralysis. And the orthopedic surgeon would be able to assess the imaging, look at the bones, look at the fractures where they're located. And if they think these are compromising the spinal cord, then they may in fact try to stabilize the spinal cord. In persons with intractable pain as well, persons who might not be able to tolerate the pain medications, or in whom these pain medications are just ineffective, and sometimes you might need to go the route of surgical intervention. But it's not typically primarily used for straightening the spine. There have to be other reasons because the risks of surgery are high as well in this group of patients. Most of them are elderly, they may have other comorbidities, cardiovascular disease, and surgical intervention does not come without risk. So you have to weigh the risks and the benefits in each patient.
Wow, yes. Well, I'm glad that there are, a number of options available. As you say, cosmetic effect is not necessarily enough to justify doing surgery. I've heard of this procedure, at least it's been being done locally as well. They call it vertebroplasty, where you actually inject some cement and try to, with a balloon into the vertebra and try to kind of open it up a little bit.
Right.
You've heard a little bit of that.
What's your take on that? The technology is just way beyond me. That is something I can't say I'm an expert to comment on the orthopedic interventions. I do know it exists and it has been used in persons with osteoporosis with positive effect.
Yes.
Probably something I would need to brush up on my reading about.
Yes, I've had a few patients have that, so,
I've seen it as well.
Yes, a couple of people. So that's at least not, surgery as such. So there are a few options, but of course, the best thing is prevention, as we've seen. So we've gone a little over time, but we just had a couple of questions that were very specific and we didn't want to miss it over.
Okay.
One, actually, I think we covered most of them. Oh, here is a specific question that we didn't want to overlook. It has to do with one of our members from the West, proudly from the West, and she's saying that she's noticed some twisting of the hands at the thumbs, and she's wondering if it has to do with the lack of calcium. So I'll probably jump in here, but if you want to comment.
Of the hands. So the question would be, is this something acute or is this something chronic? Because by twisting of the hands, I'm not sure if this is something that comes on intermittently and then goes away, or this is something that she's noticed over a longer period. Low calcium can cause some abnormal movements in the hands. But if these are joint deformities, then I would probably think that's not necessarily related to calcium and would probably be along Dr. Tollery's specialty area.
Yes, you probably want to show them to your rheumatologist and see. But I know that it may not be a calcium issue if it's actually the joint that is twisted. So there's an issue you can get with lupus with that, where the joints kind of get lax and so they look bent. So the best thing is to show your rheumatologist the hands, and but it may not be a calcium issue. So we have a couple more questions coming in the chat, really good questions. One is, we're having, well, is there a limit to how long one can take Fosamax? You might want to tell the group what Fosamax is for those who are not sure.
Fosamax is one of the medications that reduce the breaking down of bone, pretty much. So over time, it helps to maintain bone density and has been shown to reduce the risk of fractures. Now, this is quite a good question. I'm happy you asked this because it's one of the drugs that falls under the group bisphosphonates, and we would typically say we continue to treat patients who are at increased risk of fractures for at least 5 years on bisphosphonates. There is what we term the drug holiday, where after treating individuals for, say, five years, we might consider holding back the bisphosphonates and probably reassessing to see what their fracture risk is, and possibly introducing an alternate agent, which has also been shown to reduce fractures. And one of the main reasons for this is that there is a small risk of what we call atypical femoral fractures, so fractures of the thigh bones. Long-term bisphosphonate use may increase this risk. It is not seen very often, but it is something that individuals need to be made aware of. So I would say in individuals who are not at such a high risk, You could consider drug holiday after 5 years, and possibly substitute with another agent if we think that risk is high enough. But each individual needs to be managed on a case-by-case basis, and that's something that probably we need to discuss, or you would need to discuss with your physician to assess what your fracture risk is and whether the risk outweighs the benefit.
That's really good. I mean, what a great question. I mean, I remember when there's a lot of back and forth about that issue. You know, these atypical fractures, they're rare, they're not common. And then they had this data saying that, you know, you can, you know, if you stop to get holidays, you actually can lose the benefit that you gained from, from the drug. So it's a nuanced thing. So it's really important for your doctor who actually understands your risk situation best to help you kind of weigh that and see what the best course is for you. Here's another one. I have serious lower back pain. What can I take? And you know, one of the things I just want to jump in on this one to save you time, because it intensifies when I walk long distance. And I don't want to make snap diagnoses here, but one of the things that we've been hearing is that pain is not the primary indicator of osteoporosis or a bone density issue. Most of the time, in my experience, there's usually some other issue. There's an issue with your disc, or there's an issue with the muscles that support the spine. And that's usually the most common thing to give you that sort of symptom, especially if it's in your lower back. Right. But it's really important, like, to know what the situation of your health, your bone health is. And we didn't get to talk about, like, how do you know? Right. You said that you can't judge off symptoms, but how do you know if there's a bone density issue, and when should you test?
Yes. Right. So the test that we typically send patients to do is what we call a DEXA scan, which is a low intensity X-ray scan. Patient lies on a bed still, and the machine passes over them and takes a picture highlighting the bones. We do see other things like fat and muscle mass, but to make the diagnosis of osteoporosis, you're looking for specific numbers to say where your density falls. So this is something we would typically want individuals who are on long-term steroids. Certainly for persons who are on more than 5 milligrams of prednisone or the equivalent in other types of steroids for more than 3 to 6 months. So just to have a baseline, and then assessing as we go along to see what the indication would be like to repeat the test. If it is that we've detected osteoporosis, or if we notice the bones are weak, but not quite to the point where you would say it's osteoporosis, then there are measures that can be put in place to improve bone density and reduce fracture risk.
Wow, okay, that's awesome. So you can do these x-rays, they're not hard to do, not too much radiation, and you can actually know what the status is with your bones. It's a great idea. You don't have to wait until after menopause, because as a lupus patient, you may have risk factors. Talk to your doctor, see if you need to be tested, screened a bit earlier, right? And there's so much more. I can't believe how time has flown. It's such a great topic. Looks like we have to plan a part 2 on this one. And we even had other bone issues that we probably have to talk at another time about osteonecrosis. And that's a different condition that we have to look out for. But this has just been awesome. We've just had a great time, you know, having you here, Dr. Francis-Emmanuel. Where do people find you, like when they want to find you? Suppose they want to come see you.
I shared my email address. I'm at 1 Arden Road, Kingston 10. And I can reach the email address that was in the chat earlier.
Yes, I think we know a couple of other people who are there, so that's good. Not the first time the group is hearing that address. So you can find her, and we could probably have another session talking about the bones in the near future. So we really thank you. You got lots of take-home messages here. We got lots of take-home messages here. So we need to maximize our bone health, do all the right things. You know, you talked about dairy, but I've been told, I've learned that there's so much calcium in a lot of things, in greens and beans and broccoli and all these wonderful things. Eat your sardines with the bones, people.
Which is more tolerable.
And check, make sure you're having enough vitamin D, because you may not get a lot of sun, your absorption may not be great. So make sure that if you need to take vitamin D supplements, if there's a concern, you might even need to measure your levels. So do that exercise, your weight bearing exercise. Don't stay on too much steroids too long, right? Don't give your doctor a hard time when they're trying to get you on something else. So just think about the benefits and, you know, check that bone density, and, you know, talk to your doctors about your medication options. No matter what the stages of your situation of your bone, there is something to benefit from. And so thank you. We look forward to seeing you again.
Thank you,
First
Dr.
Wednesday.
It's a pleasure.
Thanks so much. Thanks so much, Patrice. We'll be back first Wednesday of the next month. That's the month of May. Lupus, World Lupus Day is May 10. And we also have our support group meeting coming up with a special guest. Update your membership so that you get invitations to these special events. You know, and stay tuned so you can get our newsletter. Thank you so much for joining us. Thanks for your great questions. Good night, everybody.
Good night, everyone. Take care. Thanks again.
Stay safe.